This is going to be Pediatric Emergencies Part 1. More than 20,000 pediatric deaths occur in the United States per year. The number of ill and injured pediatric patients requiring critical care transport has increased. The critical care transport team must be able to provide the same level that exists in the PICU or pediatric ICU, and consider the transport pediatric ICU extension. Relative anatomy and physiology. Starting at the top here, they have a larger surface area for their actual weight, makes them susceptible to hypothermia. Let me switch this pen here. Anterior fontanelle and open sutures are palpable up to about 18 months. The posterior fontanelle closes between 2 to 3 months. Their tongue is larger relative to the small nasal and oral airway passages. If they get an upper respiratory infection, it can very easily lead them to hypoxia. Short, narrow trachea in children under 5 years makes them susceptible to foreign body airway obstruction. Until late school age and adolescence, the cardiac output is rate dependent. This is going to be very important. Not stroke volume dependent, making the heart rate more rapid. Abdominal area offers poor protection for the liver and spleen, making them susceptible to trauma. Until 12 to 18 months of age, the kidneys do not concentrate the urine effectively and do not exert optimal control over electrolyte secretion and absorption. If you see an infant that has concentrated urine, they are in a varying form of hypovolemia. Until later school age, proportion of the body weight in water is larger and more water in the extracellular spaces. Daily water exchange rate is much higher. Blood volume is weight dependent, 80 milliliters per kilogram. Muscles lack tone and power and coordination during infancy. Muscles are 25% of the weight in infants versus 40% in an adult. Until puberty, the bones are soft and more easily bent and fractured. Up to about 4 to 5 years of age, the diaphragm is the primary breathing muscle. CO2 is not effectively expired when the child is distressed, making the child susceptible to metabolic acidosis. Until about 10 years, there is a faster respiratory rate. Fewer and smaller alveoli and less lung volume. Tidal volume is proportional to their weight, 7 to 10 milliliters per kilogram. Until puberty, percentage of the cartilage in the ribs is higher, making them more flexible and compliant. This is going to decrease our ability to expand the lungs fully. Higher metabolic rate, higher oxygen needs, higher caloric intake. Heads proportionally larger, making the child susceptible to head injury. All brain cells present at birth, myelination and further development of nerve fibers occurs during the first year. Physiology of Metabolism and Thermoregulation. Their surface area to volume ratio is 4 times that of an adult. Their heat production is only 1.5 times as high. So they have a greater risk of hypothermia. Heat loss results from convection, radiation, evaporation, and conduction. Air blowing over the actual ambient air temperature. If they're wet, evaporation, cooling on the surface of the skin allows for quicker heat reduction, and then conduction. If they're on a cold surface, they are going to chill out or cool very quickly. Underdeveloped muscular innervation. There's no shivering for thermogenesis or the creation of heat. Higher basal metabolic rate than that of an adult. Increased oxygen consumption, almost 2 times that of an adult. Increased risk of hypoxemia and hypercapnia or high CO2 levels. Infants are at a greater risk for hypoglycemia, and this is secondary to decreased glycogen stores, immature hepatic development, decreased glycogenolysis, increased metabolic rate, increased glucose requirements, or any sort of diabetic history. If the parents have a diabetic history, this could also be prevalent in the actual pediatric history. Looking at them, generally this is passed from parent to child. Blood glucose levels should be determined for all patients, especially those with histories of seizures, dehydration, irritability, or cardiac arrest. Signs and symptoms of hypoglycemia: limpness, twitching, eye rolling, irregular respirations, apnea, seizures, altered mental status, or loss of consciousness. Before transport, determine their blood glucose, identify glucose requirements during transport, and initiate a glucose infusion before transport, as necessary. Airway anatomy and physiology. Pediatric patients have a unique airway anatomy and physiology compared to that of an adult. In a child, proportionally the head is larger. Infants are obligate nose breathers. Larger, more flaccid tongue. Cricoid cartilage, the narrowest part. It's a funnel-shaped airway, is the first cricoid ring. Larynx is more superior and anterior. If we'll look here, in the adult airway, it's down a little lower. In the pediatric airway or a child's airway, it's much higher. Proportionally larger occipital area. Epiglottis is more cephalid, elongated, and flexible, making it more difficult to intubate. Loosely attached mucous membranes, which makes the whole airway more flaccid. Airway and anatomy physiology. Differences. Pediatric tongue is larger relative to an adult oropharynx, which means there's less room for airway swelling. If a child's upper airway swells, it can create multiple problems. Upper airway stridor, no air entry, increase of hypercapnia, increase of acidosis, greater risk for airway occlusion is the simple answer on this one. Differences continued. Pediatric external narrows are proportionally smaller compared to that in adult. They may occlude easier. They're subject to edema from upper respiratory infections, mucus, blood, tissue hypertrophy of any sort. Pediatric trachea is more narrower and pliable than that of an adult. Pliable trachea is subjective to occlusion from hyperextension or hyperflexion. There's a sweet spot for opening the airway on a child or an infant. Since it is more pliable, if we have their head over hyperextended, it will occlude their airway. If we have it flexed, it will occlude their airway as well. So please place them into a sniffing position. Narrow trachea is at risk from occlusion from swelling, mucus, blood, or new tissue development or neoplasm, as in a tumor. Differences. Pediatric epiglottis is larger, less supported, and omega-shaped compared to that in an adult. Difficult to identify during intubation. Difficult to control during intubation. This is why it's suggested that we use a straight laryngoscopy blade is recommended for actually intubating pediatric patients. False vocal cords. This is your glottic opening here. Smaller in size. An adult airway is the size of a dime. Pediatric airway is 1/3 that size. So you're hitting a smaller target and it is more interior. Pediatric larynx is more superior and anterior. Location in the adult, it's the level of the 4th or 5th cervical vertebra. In the pediatric, it's the level of the 1st or 2nd cervical vertebra. May make visualization of the cords during intubation difficult. The narrowest part of the pediatric airway is at the level of the cricoid ring. An adult airway is cylindrical shaped, so whenever we see the glottic opening, it doesn't get smaller on the inside. Airway is shaped like an inverted cone with the narrowest part at the first cricoid ring. So whenever we place an uncuffed ET tube, the narrow cricoid ring acts as a physiological cuff when the endotracheal tube is placed in it. So we need to feel just a little bit of a friction fit. There needs to be a little bit of tension at the very end of the intubation. And this is because that the cuff is going to fit into that cricoid ring and seat there. Pediatric group cage is not completely calcified. It's more flexible than an adult. So is the sternum. Cannot support the lungs against high negative intrathoracic pressure. Large volume ventilation attempts. If you try to ventilate large volumes, at some point it's going to take the path of least resistance. It's either going to pop off. If you have an uncuffed airway, it's going to pop off and displace the airway if you overventilate them. Under BLS methods, whenever you're ventilating them. Whenever you see equal rise and fall of the chest, stop at that point. It'll take the path of least resistance. So the path of least resistance would be the esophagus. Rib positions is more horizontal. Little leverage during intercostal muscle contraction. Less lift on the ribs during inspiration. Less increase in anterior-posterior diameter. Less increase in interthoracic volume. It means less tidal volume. Less developed accessory muscles. The younger the patient, the less developed the muscles. Combined with decreased rigidity of the chest wall, contributes to diaphragmatic breathing. Lower pulmonary reserve capacity than that of an adult. Large heart decreases room available for lung expansion. Small abdominal cavity and relatively large abdominal organs impedes the diaphragm's movement. Decompressing the stomach can increase diaphragm motility. If you have a pediatric patient that has been attempted ventilation under BLS methods, and there's any possibility that the stomach has air in it, please decompress this before ventilate, or ventilate a little bit and look at the rise and fall of the chest. This can be facilitated through an orogastric tube or a nasogastric tube. Alterations to cardiac output. Pediatric heart can increase in rate, it cannot increase in contractility. Bradycardia suggests drastic reduction in cardiac output. Normally, in an adult, we have three things, and this is a simplified look at the cardiac output formula: heart rate, contractile force strength, and peripheral vascular resistance. Now, in the middle here, we have fluid, or an adequate amount of blood volume. These are the three things that we can adjust along with the fluid. If an adult's heart rate goes down, contractile force and peripheral vascular resistance, as long as there's enough fluid, will make up for the deficiencies. In the pediatric patient, they don't have contractile force strength. They have peripheral vascular resistance and heart rate. If the heart rate goes down, peripheral vascular resistance is the only thing maintaining blood pressure and adequate amounts of fluid. Your normal cardiac output formula. Cardiac output equals stroke volume times heart rate. The stroke volume carries two equivalents on this simplified version. The fluid volume and the contractile force equals the amount of stroke volume that's ejected out of the heart. Peripheral vascular resistance. Pediatric populations can achieve significant arterial vasoconstriction. Results in the maintenance of systolic blood pressure, decreased organ perfusion. Also, if they get a high amount of peripheral vascular resistance, it's going to decrease the amount of blood supply to their actual organs. This increases a high index of suspicion required to treat diminished end organ perfusion before it's clinically evident. So very simply, these guys will compensate through their two mechanisms, which is heart rate and peripheral vascular resistance. This, though, increases CO2 levels and increases acidosis at the tissue organ sites. They will maintain these two until it is clinically evident, and then they'll crash. General pathophysiology of the pediatric patient. Pulmonary pathophysiology. Causes of respiratory compromise include airway obstruction, foreign body of some sort, edema to the upper airway, bronchospasm, trauma, infection, and congenital heart defects. Respiratory compromise is the leading cause of cardiopulmonary arrest in the pediatric patient. Airway maintenance and ventilation are vital. Respiratory distress, failure, and arrest. Clinical evidence of respiratory distress indicates that a patient is using physiological mechanisms designed to maximize their pulmonary function. Compensatory mechanisms will fail in time. Respiratory and cardiac arrest will follow. Goals to provide basic and advanced life support early to prevent cardiopulmonary failure. The quicker that you identify a clinical reason and initiate BLS and ALS, the better the pediatric patient is going to do. Clinical presentations of respiratory distress and failure. Increased work of breathing, tachypnea, the use of accessory muscles, nasal flaring, diaphoresis, tachycardia, and this is defined by patient's age, irritation, inspiratory retractions, excessive abdominal motion, grunting. In the pediatric patient, grunting is a physiological peep. In the older patients, we see them as they become hypoxic and chronically hypoxic. We see them purse their lips. In the pediatric patient, this is a physiological result. Their upper airway will take over actions on this and cause them to grunting. Grunting is caused from them trying to expel air on a closed airway. Pulse oximetry and end tidal capnography changes to normal breathing sounds. Wheezing, pulmonary edema, respiratory failure, altered mental status, muscular hypotonia or flaccidness, tachycardia progressing to bradycardia, lowering systolic perfusion pressure, their blood pressure keeps going down and down and down, pallor and cyanosis, loss of vesicular breath sounds, irregular respirations. Etiology of respiratory compromise is not always identifiable, so please start off very basic, cover your bases, and advance from there. If a clinical indication is found, get ahead of the physiology as soon as possible. Clinical presentation of respiratory distress. On respiratory failure, inability to load themselves, inability to breathe. This causes hypercarbia and acidosis, which leads to also hypoxia, which will eventually cause the pediatric heart to become bradycardic, decreases its contractility. They already have this in place. If it becomes bradycardic, the ejection fraction goes down even more. This causes decreased blood flow, decreased muscle tone, hypoventilation or decreased ventilations, which leads to respiratory arrest and then cardiac arrest. This ends section 1. If you have any questions, feel free to contact me. Name's Roy Smith, roy.smith@redlandscc.edu or smith@imsa.net. Thank you.